Delirium is a common, serious, and potentially life-threatening condition in older adults. It occurs most frequently in hospitalized patients, but also is seen in older adults residing in nursing homes and in community settings. Delirium is associated with increased morbidity and mortality and results in greater healthcare costs. Despite the burdens associated with delirium, it remains poorly understood and it is often under-recognized and undertreated. In this module, I will define delirium, discuss its epidemiology, identify common risk factors and etiologies, describe clinical manifestations, review assessment techniques, and discuss prevention and management strategies. I will also distinguish delirium from dementia and depression, common and often overlapping psychiatric conditions in older adults. Delirium is a potentially reversible pathophysiologic condition characterized by the rapid onset of altered arousal and attention, impaired cognitive functioning, distorted perception, and disturbed psychomotor behavior. Delirium is common among hospitalized older medical patients. A recent review by Inouye and colleagues found that the prevalence of delirium at admission ranged from 18 to 35%, and that the overall occurrence of delirium on general medical and geriatric units ranged from 29 to 64%. Higher incidence rates were noted in intensive care units and in postoperative and palliative care settings. While the prevalence of delirium among older adults in the community is low, about 1 to 2%, the prevalence on admission to the emergency department is 8 to 17%. The prevalence of delirium on admission to the emergency department and hospital suggests that delirium develops before admission and may be a primary factor resulting in admission. Delirium is associated with multiple adverse outcomes, including increased complications such as aspiration, pressure ulcers, pulmonary emboli, dehydration, and falls, accelerated cognitive decline, and persistent cognitive impairment, impaired physical function, increased length of stay, nursing home placement and institutionalization, increased mortality, and increased healthcare utilization and costs, both during and after hospitalization. In addition, delirium causes significant psychological distress for patients, family caregivers, and healthcare professionals. The clinical presentation of delirium is variable. Symptoms fluctuate over the course of the day and often worsen at night. Patients with delirium have periods with reduced awareness that alternate with periods of lucidness. They may exhibit altered alertness, impaired attention, disorientation, poor memory, disorganized thinking, and perceptual distortions. Patients with delirium often have disturbed sleep patterns, including increased daytime sleepiness, nighttime agitation and restlessness, or complete reversal of their sleep-wake cycles. They also may exhibit blunted or labile emotional responses. Delirium can be classified into 3 subtypes: hyperactive, hypoactive, and mixed, based on psychomotor behavior and level of alertness. Prodromal symptoms such as anxiety, distractibility, restlessness, irritability, drowsiness, and changes in sleep are common in the days and hours before the onset of delirium. Unfortunately, these symptoms are nonspecific and may be seen as normal for the patient's condition. In patients at risk for delirium, subtle changes in behavior and cognition should be regarded as significant. Many risk factors for delirium have been identified. Common risk factors include older age, pre-existing cognitive impairment or dementia, having a prior history of delirium, severe illness, comorbidity, functional impairment, immobility, sensory impairment, polypharmacy, having a history of alcohol abuse, and malnutrition. The etiologies of delirium are diverse and multifactorial. Delirium often reflects the pathophysiological effects of an underlying medical condition, drug effect, or complication. In older adults, delirium is a common presentation of an acute illness. Thus, it should be viewed as a medical emergency. A number of medical conditions may be associated with delirium. Delirium may also be caused by an alcohol or drug intoxication or withdrawal. Many commonly prescribed and over-the-counter drugs can cause delirium. In high-risk patients, such as those with dementia or the critically ill, environmental factors and changes can precipitate delirium. The timely and accurate detection of delirium is limited. Clinicians fail to recognize delirium in 1/3 to 2/3 of cases. The reasons for the under-recognition of delirium are complex and include characteristics of delirium itself, such as its variable presentation and fluctuating nature, its overlap with other common psychiatric conditions such as dementia and depression, ageist views and beliefs, that is, that hospitalized older adults are expected to become confused, the lack of routine cognitive assessment, and the failure to appreciate delirium as a potential medical emergency. Too often, delirium is recognized only when hyperactive symptoms such as agitation and restlessness are present. Hypoactive delirium is frequently not recognized. The hypoactive symptoms may not be seen as a problem, or they may be misattributed to fatigue or depression. Delirium may co-occur with depression and dementia, making its recognition and diagnosis more difficult. Because delirium is commonly misdiagnosed as dementia and/or depression, clinicians need to know and recognize the key characteristics that distinguish each. The onset of delirium is acute. It develops abruptly over hours or days, whereas the onset of dementia is slow and progressive. Depression develops over weeks to months and may be situational. Delirium symptoms fluctuate over the course of the day and are often worse at night. Symptoms of dementia are stable over the course of the day. Its disease course is chronic, ongoing, and progressive. The course of depression tends to be stable or with situational fluctuation. Delirium detection can be enhanced by routine cognitive assessment and the use of delirium screening instruments. Knowing a patient's baseline cognitive status, level of functioning, and physical health is crucial for recognizing delirium. Clinicians should establish an accurate baseline by performing a thorough cognitive assessment and obtaining information from family caregivers. After a baseline is established, a brief cognitive assessment should be included in routine and ongoing assessments. The CAM provides a brief, validated diagnostic algorithm that relies on the acute onset of symptoms and fluctuating course, inattention, and either disorganized thinking or an altered level of consciousness. The CAM is widely used in clinical and research settings. In addition to the assessment of cognitive function, additional assessment strategies should focus on the identification of acute physiological disturbances and medical conditions that may be causing the delirium. These strategies include obtaining the patient's history and performing a physical examination, doing a complete medication review, and conducting targeted laboratory and diagnostic testing based on the patient's history and physical exam. Delirium is a potentially preventable condition. Prevention strategies center on the identification and correction of modifiable risk factors. Inoue and colleagues demonstrated that at least 40% of delirium cases may be prevented through the implementation of a multi-component approach targeting 6 risk factors: cognitive impairment, immobility, dehydration, sleep deprivation, vision impairment, and hearing impairment. The multi-component intervention included protocols that provided orienting communication and a daily schedule, therapeutic activities to enhance cognitive stimulation, early mobilization, volume repletion, non-pharmacologic sleep enhancement, and vision and hearing adaptations. This delirium prevention intervention strategy has been widely disseminated through the Hospital Elder Life Program, or HELP, which has been implemented in more than 200 hospitals worldwide. Pharmacologic prevention strategies have been studied, but no convincing reproducible evidence of effectiveness has been reported. Thus, pharmacologic approaches to delirium prevention are not recommended. As with delirium prevention, the management of delirium also requires a multi-component approach. The first step is to identify and treat all potentially reversible conditions that may be contributing to the delirium. Non-pharmacologic interventions involving supportive care, environmental, and psychosocial strategies should always be used in caring for patients with delirium and those at risk. In addition to delirium reversal, the goals of delirium management are to promote patient safety and prevent complications. Supportive care strategies include ongoing assessment and monitoring, ensuring adequate oxygenation, hydration, comfort, elimination, and nutrition, promoting mobility, avoiding physical restraints, and conducting a thorough medication review, and eliminating all non-essential medications. The lowest possible dose should be used for medications that are necessary. Environmental strategies include providing reorientation and support, using calendars, clocks, pictures, and other familiar objects, ensuring appropriate levels and types of stimulation, maintaining normal schedules and routines, providing adequate and appropriate lighting, and ensuring the use of glasses and hearing aids. Psychosocial strategies include providing psychosocial support to the patient and family, educating the family about delirium and the patient's condition, encouraging a calm family member to stay with the patient, and using concrete, simple, face-to-face communication when interacting with the patient. Pharmacologic intervention should be reserved to treat distressing behavioral symptoms such as severe agitation and distressing psychotic symptoms such as hallucinations and delusions, and to promote patient safety. In summary, delirium is a common, serious, complex, and potentially preventable source of morbidity and mortality in older adults. Despite its potential for harm, delirium is poorly understood by clinicians. The under-recognition and under-treatment of delirium is a significant public health problem. Comprehensive and widespread efforts to educate clinicians and the public about delirium are needed. Prevention and early recognition are key steps in successful delirium management. Early recognition may result in earlier intervention and improved outcomes. Non-pharmacologic interventions aimed at delirium risk factors and etiology should always be used to prevent and manage delirium. Pharmacologic intervention should be used only when needed. The prevention and management of delirium should focus on maximizing patient function, enhancing recovery, and improving clinical outcomes.